Before we get started, we open up with our customary ways. We started an opening prayer. The protocol is followed. Tobacco was offered. At this time, I'm going to get our volunteer, our elder, our delegate from Peguis, Doris Bear, to bless us with the prayer to start our meeting in a good way, for good energy, good vibes, but more importantly, a good dialogue. So, Doris, can I get the floor mic to Doris? Okay. Bless you.
Good morning. Good morning, everyone. My name is Doris Bear. I'm from Peguis, and I'm glad to be here. I will be joining on all of the meetings from today forward. So I'll just open up with a prayer. Lord, I ask for your guidance and support for this health legislation meeting that we're having today. Bless all the participants and the leadership. Lord, I pray for all of the families that are out home that are suffering from drug and addictions. And Lord, I pray for guidance and give us the right decisions to make in this health legislation. I pray that we don't lose our rights as an Indigenous peoples. Help us and guide us and give us all the support that is needed. Put your hand upon each and every one of us here, Lord. In Jesus' name I pray. Amen.
He was sounding me good. Thank you, Doris, for that beautiful opening prayer. So for the people that don't know me, I'm Willie Moore from the Nisjasi Cree Nation. I'll be your chair for the next 2 days and the next couple weeks with the follow-up meetings. So we have an agenda here for this morning. We have 3 presentations. So after our opening remarks by our lead facilitator, Chief Derek Nepanak of the Pine Creek First Nation, we're going to go to a presentation that's going to be done by our FNHSSM staff, co-facilitator Mary Jane Armstrong. Mary Jane is the FNHSSM privacy officer and legal assistant. She's going to do a background and why we are gathering for the next 2 days for the seminar and the FNHSSM approach and mandate. So after Mary Jane's presentation, we're going to have a presentation by Louis Harper. Louis is the FNHSSM senior legal technical advisor. He's going to do a presentation on the history of First Nation health legislation, development, and policies. So after Louis' presentation, we're going to have a quick 10-minute break. Then that's going to take us to a presentation on introduction to health legislation policy, and that's going to be done by Al Garman. She's a CSCO advisor, and she's going to do a presentation, what does the Canadian healthcare system look like, and the legislation, how it was developed, approved, and the regulation. That's going to take us to lunch. So at this time, I'm just going to call the meeting to order. Like I mentioned before, to answer, my name is Willie Moore. I'm your chair for the next 2 days. So we're going to get right into the agenda. At this time, we're going to have opening remarks from our lead facilitator. And that's going to be done by Chief Derek Nepanak. Chief Nepanak is the chief of Pine Creek First Nation and a good buddy of mine, somebody I always looked up to. And a guy that needs no introduction, right? And then, well versed in his presentations and his knowledge on all the issues that we face, in our communities. So without further ado, I want to introduce our lead facilitator for the next 2 days, Chief Derek Nepanak.
Miigwech. Is this on? Yeah. Indigenous. I'm Derek Nepanak, and it's my great honor to be identified as the lead facilitator for this discussion over the next couple of days. I want to acknowledge Doris for her prayer to get us started in the right way this morning, and of course the very delicate balance between recognition of the treaty right to health, as what's often been referred to as the medicine chest clause in treaty, and the contemporary realities that we live with when it comes to health outcomes and health services for Indigenous people across Turtle Island. I myself had been involved in the discussion for a number of years prior to becoming the Grand Chief at the Assembly of Manitoba Chiefs. I was, of course, Chief in my community, Pine Creek First Nation. And I saw a lot of shortfalls in terms of expectations, in terms of outcomes of what we'd expect as health standards for our people in a contemporary Canadian society. The challenges carried on when I became the Grand Chief in 2011, and I became more aware of these challenges. I became more aware of them because I started to see how other communities were I guess, subjected to similar or worse standards of healthcare services than my own community in Pine Creek. And I began to contemplate, well, why is this happening to us? Why do we seem to be on the receiving end or the short end of the types of qualities and services that other people were receiving in even rural communities and urban centers, of course, having the best access to healthcare? And it brought me into an even further level of inquiry. I had talked about this many times, and that is the commodification of us as Indigenous people. And when I say commodification, what I'm referring to is the creation of the statutory Indian has led to the opportunity to take economic advantage of us as people who receive a lesser degree of access to services. I began to see that there's no money to be made on an Indigenous person who's healthy, but there's lots of money that can be made on an Indigenous person that requires regular and ongoing access to, pharmaceuticals, doctor visits, and of course chronic illness as well leads to, a very, very robust health economy that we contribute to. So with that in mind, I began to think about, well, how do we take some of this control back, and how do we begin to introduce our ways of well-being back into the discussion? And I engaged at that time some of the best minds I thought that are out there, and that I know that are out there in the area of health and health innovation. We began to create the concept of a breakaway group from the Assembly of Manitoba Chiefs that would later become the First Nations Health and Social Secretariat of Manitoba, and began think tanking and workshopping this idea around federal legislation, or not. It wasn't even called federal legislation at the time. It was called just roughly and broadly an Indian Health Act. And what form and shape would an Indian Health Act make in the face of the need to uphold the treaty right, but also the need to create enhanced and better services and access for our people? So, we ventured out, we engaged, as I say, policy and legal experts, constitutional legal experts, to start thinking about how this would take shape. We met with Minister Leona Aglukak at the time, the Conservative Minister of Health, an Indigenous minister, part of the Stephen Harper government, and she said that the Canada Health Act would not be on the table. It would not be part of the discussion. And that was disappointing, because we thought that there was a real need for innovation, a real need to transform health services. And unfortunately, we met up against a government that wasn't really interested in doing anything to the benefit of what we saw would be a benefit for our people at the time. So fast forward to where we're at today. I believe that the tide has changed. I believe that there is opportunity, and we've seen it in the last number of years. We've seen a shift in the federal legislative agenda to take a more holistic approach to how it views how Canadians and citizens are governed under Canada's Constitution. And an express recognition of inherent and treaty rights, I think, is right there at the doorstep for many sectors of how we live within the Canadian context. We've recently seen, of course, introduction of what we still refer to as Bill C-92, and that is the federal recognition legislation on Indigenous children and families. We've seen Indigenous language revitalization. And what this legislation does is it creates an onus, not necessarily on us as treaty people, but more on Canadians to live to a standard that they themselves expect for themselves. And that, in many ways, I think, brings us into an opportunity to, or discussion anyway, to create the opportunity for us to build better systems and better services. And I think that applies equally in the health context. And I think that can be done without compromising the treaty right to health. And I know that some people out there would say that, the medicine chest clause has to be protected at all costs, and I would agree 100% with that. But what is the content of the treaty right to health? What's in there? And I think that part of our discussion should be to perhaps reflect upon what has the treaty right to health been for us, and what could it be for us if we were willing to move forward in time and recognize that well-being is really the criteria for adequate and fulsome health services. And if we were to determine what well-being would be, would the current state of health services actually accommodate that? Or is there something more? I'm observing today, as I speak, young people going out onto the land. Education curriculums are shifting in the communities, and more of our young people are being introduced to the medicines that can be picked and harvested right from the shoreline or right from the prairie, close to home. More and more young people are beginning to see the value of our sacred medicines and incorporating that into their diet. Diabetics in our community are using traditional medicines to manage their blood sugar. A more holistic approach is upon us. And I think that these ideas and these age-old concepts that were almost forgotten are now renewing themselves. And we're reclaiming space in Indigenous wellness that could be enhanced through potentially a more broad national discussion. And I think that that's part of the impetus for this process, is to give space and give room for Indigenous health services as we understand them. For decades and perhaps generations now, we've been told that your best way to health is to go to the doctor's office and talk to the doctor about what's wrong, and then they'll give you a prescription or they'll give you medicine. I don't think that that's the comprehensive approach to well-being that we know as the original people of these lands. I think that it's a much more comprehensive solution that we seek, a solution that incorporates, of course, our land-based teachings, but a land-based relationship. Because as we remember and recall, our elders have told us, if the land is sick, the people will be sick. So there is a reciprocal relationship with the land that we have to be wary of. It's not just about relationships between humans, not just about relationships amongst ourselves. It's got to be about land-based approaches and understandings of the medicines that we have oftentimes in our own backyard. And I believe that this opportunity that we have right now to have an engagement discussion about what legislation might look like incorporates these opportunities for us, or it could incorporate these opportunities for us, leading to a potentially much better, I guess, environment when it comes to health and well-being. So that's kind of why I'm involved in the process, and I'm really grateful that the Health and Social Secretariat considered me to be part of this discussion. I'm a very, very strong believer in our treaties, and I have never believed that the ability to go to the doctor and get a prescription and have it paid for, I've never believed that that's our treaty right. I've always believed that our treaty rights to health have always been about ensuring that we had access to the full pharmacy, the pharmacy of the land, and understanding and always recognizing and knowing what our medicines are and how we take care of ourselves, not just as a health response, but as, a pursuit of well-being. And I think that's what this discussion could be about. If the discussion is reduced to, this idea that, you have to reject federal legislation because we're going to lose our treaty right, then the fight is already lost. But if we open up our minds to a possibility that our treaties cannot be touched by federal legislation, there was a process at treaty time that forever locked in the opportunities for treaty. And that process was sacred. That process was ceremony. And when those pipes are lifted at treaty time, that created a perpetuity of that promise. And that promise will continue forward. And that commitment to treaty will continue forward. Whether people recognize it or not, it will always be there. And it does not know time. It does not expire, or it does not become terminated or exterminated by the will of man, because it's been taken beyond the capabilities of man and into the realm of spirituality and sacredness. That's what treaty is about. No piece of federal legislation, no piece of paper that crosses the floor in the Senate or the House of Commons and passes into law in Canada can ever take away the treaty, because, like I say, the treaty is a much more comprehensive relationship than what Canadian colonial government can create in their man-made laws in Ottawa. So I believe that treaty is preeminent in the discussion, and I do believe that a discussion around health legislation can occur without going to the heart of treaty. I believe that today's legislators in Ottawa, the Liberal government, believe that there should be a level of equality in the human rights context. And I think that is the reason why they're willing to have this discussion, is because they see the deficiencies in the current standards of health, and they want to help be part of creating the solution. I think we should be open to those discussions, and I think that it should be a dialogue that we fully engage in, recognizing that it does not go to the heart of treaty, because our treaties are so much more than that. And so is the Medicine Chest Clause, and so is the treaties overall. So much more than a discussion that happens in this time around legislation. So with that said, those are my opening thoughts for the time being. There's much more that I could add to the discussion as we go along, but I'm very happy to be part of the discussion and to get it kick-started. Miigwech.
Right on. Thank you, Chief Nipanak, for those opening remarks. Like I mentioned, steady treaty advocate for for our communities, for our people, for our nations, and well versed and gets straight to the point. Treaty right to health, and that's why we're here. He's saying that to give us room for Indigenous health services, to include those in the health legislation revisions. So. Again, he'll be here for the next couple of days, so we'll be able to hear from him more, this morning and this afternoon and tomorrow as well. So at this time, I'm gonna invite our next presenter. Our next presenter is Mary Jane Armstrong. She's gonna be doing a presentation on the proposed Indigenous health legislation. So what the background, why we have gathered here for the seminar, and also the FNHSSM approach and mandate. And Mary Jane is the FNHSSM Privacy Officer and Legal Assistant. So this time, I'll introduce a friend of mine, MJ. The floor is yours.
Good morning. Today I'll be presenting general information on the proposed Indigenous health legislation. Next slide, please. Next slide. Next slide. One more, I think. Okay, and that's my introductory slide. Next slide. Thank you. Okay, to begin, I will share some background on recent events. In 2019, the Prime Minister of Canada mandated the Minister of Indigenous Services to co-develop distinctions-based Indigenous health legislation backed with the investments needed to deliver high-quality health care for all Indigenous peoples. The September 2020 speech from the throne affirmed the Government of Canada's commitment to expediting work to co-develop distinctions-based Indigenous health legislation with First Nations, Inuit, and Métis Nations. In support of this work, the 2020 Fall Economic Statement announced $15.6 million over 2 years, starting in 2021, to co-develop distinctions-based Indigenous health legislation. Indigenous Services Canada stated that they would work in partnership with national and regional First Nations, Inuit, and Métis Nation partners and rights holders to establish a coordinated approach for engagement on Indigenous health legislation, and that the scope of the legislation would be determined together with Indigenous peoples through input received during engagement and co-development. As Indigenous Services Canada indicated that the co-development process or structure would be informed by the engagement process, a summary of First Nations, Inuit, and Métis Nations partner input would be drafted from engagements across Canada to assist in identifying possible legislative requirement options for discussion through the co-development phase. At our March 2020 FNHSSM 7th Annual General Meeting of our membership, comprised of the 63 First Nations in Manitoba, as represented by the chiefs and community, the enactment of federal First Nations health legislation was adopted by resolution, with membership resolving that FNHSSM direct Indigenous Services Canada to provide adequate resourcing for FNHSSM to coordinate technical and leadership meetings to develop options for consideration by Manitoba First Nations on the impending Indigenous health legislation. According to the timeline provided by Indigenous Services Canada, co-analysis to jointly summarize the engagement input is currently underway, and co-development of legislative options is not far behind. Which leads me to my next slide. Next slide, please. Why have we gathered for the seminar? We've gathered for the benefit of Manitoba First Nations decision makers to explain what federal Indigenous health legislation is about First Nations might mean, with a focus on government policies and government obligations, as well as treaties and First Nations rights. The engagement approach we intend to share with you today and tomorrow is to provide an educational foundation for informed decision-making. Next slide, please. The mandate and objectives of FNHSSM are to carry on business in the area of health and social development for First Nations in Manitoba that are founded in the treaty and an inherent right and that are culturally appropriate, holistic, and community-based, and that FNHSSM will develop strategies and initiatives to promote and increase the participation of Manitoba First Nations in the control and delivery of health, and promote understanding of health and social issues affecting First Nations through partnership, research, and collaboration. Through this engagement seminar, we will be providing information on the history of First Nation health legislation development and introduction to legislation and policies, constitutional and legal background considerations, guiding international standards, the treaty relationship and treaty right to health, and different health system models. We shall facilitate reflection on the topics and will provide discussion time on proposed principles and recommendations going forward. We welcome and thank you for your participation, guidance, support, and direction. This concludes my introductory presentation. Thank you.
Right on, Mary Jane. Good presentation. Again, Mary Jane will be with us for next couple days as well and future meetings. So she's also the co-facilitator. So thank you for that, Mary Jane. Quick presentation. Again, the presentations are available, made available via email. This meeting is being recorded, so for after the meeting concludes tomorrow, the IT team can send you the presentations and the discussion that's going to happen today and tomorrow. So at this time, we're going to go to our next presentation. That's going to be done by Louis Harper. Louis is the FNHSSM Senior Legal Technical Advisor, and he's going to be doing a presentation on the history of First Nations health legislation, development, and policies. 5 series to his presentation. He's going to discuss the 1971 Wabang, or tomorrow's 1979 Indian Health Policy, and also the Health Transfer Policy of 1989, and the 1996 Royal Commission on Aboriginal Peoples of Canada, also known as RCAP, and also that's going to take us to the Kelowna Accord 2005. So at this time, I'm going to introduce our next presenter. He's joining us online. So we're going to take it over to Louis Harper, FNHSSM Senior Legal Technical Advisor.
Good morning. My presentation will be on the history of First Nation health legislation development and policies. What has been the developmental work towards creating First Nations health legislation? Evolution of First Nations health. So my presentation is going to be on 6 items. 1, the white paper of 1969, Wabang, or tomorrow's 1971, Indian Health Policy 1979, Indian Health Transfer Policy 1989, and Royal Commission on Aboriginal Peoples 1996, Kelowna Accord 2005. So we start off with the white paper 1969, a statement of the Government of Canada on Indian policy. I have an excerpt. Here's what the policy stated. The government further proposes that federal disbursement for Indian programs in each province be transferred to that province. All Indians should have access to all programs and services for all levels of government equally with other Canadians. The provinces ultimately assuming the same responsibility for services to Indian residents as they do for services to others. So that's the main policy statement that created problems for First Nations. It's a statement that basically eliminates the special status of First Nations. So this led to 2 major responses, one from Alberta, the red paper, and Wabang, or tomorrow's from Manitoba First Nations. 1971, Wabang, or tomorrow's. In 1971, the chiefs of First Nations in Manitoba published the book Wabang, or tomorrow's, in response to the government's plan to eliminate Indian status. The book represents a fundamental step towards self-determination of First Nation people in Manitoba. It outlined an agenda for action that included the inherent right to have full authority over their health systems, education reform, and child and family services systems based on First Nation worldviews, laws, and approaches. Among other things, Wabang documents the history of Indian health services and the struggles to deal with the new illnesses brought on by the Europeans. The leaders made numerous recommendations to improve the health care of their people. They proclaimed that we maintain the health services should be included in federal legislation, respecting the rights of Indians. They also declared First Nations in Manitoba their commitment to continue the long history of political action towards justice and self-determination. They recommended in the book that Canada cease pushing healthcare to the provinces. I think it's important to note also the population of treaty people in 1971. In the book, it stated that there was about 60,000 First Nations. Now we go into 1979 Indian Health Policy. Eventually, in 1979, Minister David Comby sent a memo to Noel Starblanket, the National Indian Brotherhood president at the time in 1979. He outlined the policy, the new health policy, and it had 3 pillars. Number 1, it talked about community development, socioeconomic, cultural, and spiritual development, and to remove the conditions of poverty. Number 2, the federal government to serve as an advocate of First Nations interests by strengthening greater involvement in the planning, budgeting, and delivery of health service programs. The 3rd pillar is the Canadian health system itself. Each level of government, including First Nations, has a role. First Nations on health promotion and the adaptation of health services delivery in their communities. So the idea of transferring the administrative authority for health services was born. It was first indicated in the Indian Health Policy of 1979. So what triggered after that was the community health demonstration programs, and basically that was the start of the transfer of health programs to First Nations, and that got underway in 1982. And by 1987, 5 years later, the demonstration program was over, and then the health transfer itself officially started. So now we go into the health transfer policy of 1988. It was in March 16th, 1988, the Canadian Cabinet approved the health transfer policy framework for transferring resources for First Nations health programs to First Nations control. Then in the year later, in 1989, the Treasury Board approved the financial authorities and resources to support the pre-transfer planning and the management structures. The health transfer program was at the pace determined by First Nations. It had a phase-in approach. It allowed the First Nations the responsibility for the delivery, management, and governance of healthcare. It was based on the current funding of health programs as they existed that day, and the agreements were usually 3 to 5 year agreements. Later on, the First Nations identified the pitfalls on funding and training and relating to the policies. The health transfer policy had pre-transfer planning, bridging, and the implementation of the agreements. It had 2 approaches. One was the direct transfer of programs to First Nations, and the other was an integrated approach, that one came into effect in 1994. That was when the First Nations said they needed more time to assume these programs. The mandatory programs that First Nations administered was the Communicable Disease Control Program, Environmental Program, and Occupational Health and Safety Programs, and also treatment services, like, for example, alcohol rehabilitation. It was optional, and the First Nations were able to design their own health programs. A lot of First Nations saw this as a step towards self-determination or self-government. By March 1996, 141 First Nations had assumed responsibility in health care services, and 237 First Nations communities were involved in the pre-transfer process. Now we move into the Royal Commission on Aboriginal Peoples of Canada, RCAP. That was in 1996. The Royal Commission on Aboriginal Peoples was created in 1991. The Commission stated it is to restore justice to the relationship between Aboriginal and non-Aboriginal people in Canada and to propose a practical solutions to stubborn problems. They made a statement that said the new political and economic systems that Aboriginal peoples are struggling to build will not work unless health and healing have been achieved. They also made another statement that stated the system's assumptions about Aboriginal health and wellness and how to promote them are wrong for the job. The relationship that has been developed, they said, over 400 years between Aboriginal and non-Aboriginal people has been built on false premises. So the result of this relationship was the removal of First Nations from their homelands, suppressed Aboriginal nations and their governments, undermined Aboriginal culture, and stifled Aboriginal identity. According to the Commission, the time has come to start afresh, to put the relationship on a more secure foundation based on the following 4 principles: mutual recognition, mutual respect, sharing, and mutual responsibility. The Royal Commission stated that the negotiation of treaties, either new treaties or reinterpretation or clarification of existing treaties, is the primary means for renewing the relationship. These treaties would deal with self-government and land and resources required to make self-government viable. The Commission recommends that as self-government becomes a reality, federal, provincial, and territorial governments enter into long-term economic development agreements with First Nations governments or institutions, agreements which would, among other things, transfer all of their economic development programming responsibility and funding to their institutions. One of the elements in the Commission's strategy in renewing the relationship is a new direction in social policy development, of which health and healing is the key component. They recommended the development of a system of First Nation healing centers, healing lodges under First Nation control as the prime units of holistic and culture-based health and wellness services. Governments, both the First Nations and non-First Nations, should support the development of regional agencies. The federal, provincial, and territorial governments would commit to training 10,000 Aboriginal professionals over a 10-year period in health and social services. That was one of many recommendations. The Commission calls for sufficient funding from the Canadian and First Nation governments and individuals to ensure housing needs are fully met within 10 years. In conclusion, the reorganization of health and social service delivery through a system of healing centers and lodges under Aboriginal control. It recommended a national human resources development strategy and initiation of Aboriginal infrastructure program to address the most pressing problems related to clean water, safe waste and management, and adequate housing. Lastly, the Kelowna Accord 2005. The agreement was entitled First Ministers and National Aboriginal Leaders Strengthening Relationships and Closing the Gap. It's a 26-page document, very comprehensive. It's a 10-year plan to close the gap between the Aboriginal and non-Aboriginal peoples. In particular, it had two-stage strategy process. The Kelowna Accord committed to spend $5.1 billion on the first 5 years, focusing on improving housing, water, health, education, and other social programs. They were supposed to negotiate a second 5-year agreement to address the broader and structural changes to initiate a new relationship. Of course, everybody knows the Conservative government came into power and did not support the Kelowna Accord. I think it's important to understand this accord in relation to the proposed federal health legislation for Indigenous peoples. First of all, the First Nations do not support a pan-Indigenous approach to service delivery, which they view as conflicting with their jurisdiction rights to health benefits. And that is actually very important because in the proposed federal legislation, it does say the same thing. The parties agreed to the establishment of specific framework for First Nations, Inuit, and Métis people. First Nations framework was based on special recognition of rights, treaty rights, for example. So the federal government had a role entitled National Directions for Action. They committed to improve the delivery of and access to health services to meet the needs of Aboriginal peoples through better integration and adaptation of health systems. They committed measures that will ensure Aboriginal peoples benefit fully from the improvement of Canadian health systems, and a forward-looking agenda of prevention, health promotion, and other upstream investments for Aboriginal peoples. And as well, the provinces had a role in the agreement, and so they committed to developing ongoing collaborative working relationships. I think it's important to also look at the process, how they achieved the accord. There was formal meetings that was held April 19th, 2004, with approximately 150 participants to identify major issues relating to Aboriginal communities. Then they had sectoral roundtables based on the priority areas, and then they had a policy retreat in which they looked at policy areas and development of policies relating to the accord. Then they had the ministers' meeting. In conclusion, lessons learned. The Kelowna Accord provided a model for how to successfully engage Indigenous people in policymaking. This process was not a top-down process. It was led by Indigenous people. The Kelowna Accord had an ambitious goal. And I believe that a lot of information and concepts in the Accord is worthwhile looking at in relation to to the federal legislation on Indigenous health. This concludes my presentation. Thank you.
Right on. Thank you, Louis. And a good presentation. Well written. This time I'm going to give the floor to our co-facilitator, Chief Derek Nepanax, for further comments or additions or any questions to Louis' presentation. Chief.
Miigwech. I really appreciate the depth of Louis' presentation. I think it covered a lot of key pieces in the discussion so far. Of course, even the issue around treaty and the treaty right and what compelled certain Indigenous communities to come to the table to sign treaty is even a question that was partially addressed in Louis' presentation. I thought that was very important because treaty means many different things to many different people. And as Louis had mentioned, one of the elders he spoke to, their community was compelled to make treaty because conservation was taking their food from them and basically forcing them to the table to take treaty. So when we think of treaty in that context, there's many different ways that we interpret and apply treaty, and more specifically the treaty right to health in our everyday life. So that's always going to be a difficult question to answer. One of the key points that I picked out from Louis' presentation that I thought was very important to make note of is that Canada feels that it has no legal obligation to provide health services in a legislated environment. That's going back to RCAP, and that RCAP identified that health has always been a matter of policy. I think that's a very important distinction to be made because it's true even to this day that in I believe most jurisdictions across the country that the federal government would view Indian health services as primarily a matter of policy. That is a discretionary funding pool that could be moved around subject to shifts in policy and never within a legislative framework. That issue has been there for so long that it was even addressed in the 1970s, the early 70s Wabung paper. Our Manitoba leadership convened saying that health services should be a federally legislated mandate, and that to me highlights the importance of this discussion. Is that it's been a long time coming for us as Indigenous people here to have this front and center. So. Of course, we know what happened with Kelowna. Kelowna was an example of an opportunity that floundered at the 11th hour because of changes in government. And as we engage in this discussion around legislated health services, we may also consider that we're in the 11th hour with the current Liberal government. We don't know that, but it is always a possibility that Canadians have short memories when it comes to politics, and oftentimes we see after 8 to 10 years of flip in popularity and different governments come into place. It's usually a two-party race, and unfortunately, we haven't seen the full spectrum of opportunity within the federalist system presented by other parties out there. But not to say that there's a sense of urgency here, but I think it is important that expediency is important when we look at the opportunity in front of us. So I think those are the key points that Louis has raised, and I appreciate his thoughtful approach to laying out his presentation. And I don't really have any questions for Louis, and I don't know if anybody in our audience has any specific questions for Louis, but it's very important to understand the history of policy, going back to those early times and fast forwarding to today, to see the shifts in how we've been thinking and the consistencies in how we've been thinking about this approach and this process, because in order to understand where we can go, we have to understand where we've been. And thank Louis for laying that out for us. Miigwech.
Right on. Thank you, Chief. Louis, any last comments?
No, I just want to thank everyone for listening.
Right on. Again, Louis' presentations will be available for distribution. Just contact the office and they'll email it to you. So at this time, it's going to call for a 10-minute break. It's 5 after 11. Al, so if you can stand by. Al Garvin, your next presenter on Introduction to Health Legislation and Policy. For our guests that are joining us online, we encourage you to stay online, and got a couple more presentations this afternoon. So we're going to take a 10-minute health break, and we'll reconvene at quarter after 11, 11:15. Alrighty, we're going to continue on for our first morning session here. So our last presentation, that's going to take us to a lunch break. That presentation's on Introduction to Health Legislation and Policy. That's going to be done by Al Garman. Al is a CESO advisor. But before Al starts his presentation, I'm going to get Al to introduce himself. And a little bio for our guests, for our delegates in the room, but also online. So we're going to give them, so what time is it? Because it's 20 after 8. Also, we're going to give you 40 minutes for your presentation. We're going to take 10 minutes for Q&A and some reflection from our co-facilitator, Chief Derek Niepenak, after your presentation. So at this time, I'm going to give the floor to Al Garman, his presentation on Introduction to Health Legislation and Policy.
Okay, thank you and good morning, everyone. I hope you can hear me clearly. So my background, I am a retired public servant. I've been retired for 12 years, but prior to that, I spent most of my career with what's now the First Nation and Inuit Health Branch. It was in Health Canada at the time. During the 80s, I was director of policy for most of the time. Since then, I was regional director in Atlantic region, Ontario region, and actually for 5 months, I was also regional director in Manitoba. But as I said, I'm retired now. I work for CESO, which is the Canadian Executive Services Organization, where I'm a volunteer advisor. And I've been asked to work with FNHSSM on this initiative. So my task is to put some context to the discussion you're going to have on Indigenous health legislation. I'm going to talk about legislation, regulations, and policy in general. I'm going to talk about First Nation health policy and the possibilities of legislation. And I'm going to also talk about the process that ISC, Indigenous Services Canada, has put in place to try to co-develop Indigenous health legislation. To start with, I'd like to give you a snapshot of the Canadian healthcare system, just so you have it in your mind as we're talking about these other things. So what does it look like? There's 100, probably 1,000 different pieces, but for our purposes, there are just a few key components. There are insured health services, doctors, hospitals, and what's called extended care, which is nursing homes and seniors residences, that sort of thing. These are generally provided by the provinces, but cost shared by the federal government. There is public health, which includes a range of services, including surveillance, immunization, promotion. And again, these are provided by the provinces off reserve, but on reserve, it's the federal government that takes responsibility. There is a humongous number of other health services provided by provinces off reserve, medications for seniors, eye exams, blah, blah, blah. There's all sorts of things. They're not really important for our context, but there's also non-insured health benefits, which includes a lot of those things that the provinces provide, which the federal government pays for, including medication, dental care, eye care, transportation, and a few other things. So I'd like you to keep these things in mind as we talk about the more general things and where we're going towards Indigenous health legislation. Next slide, please. So we'll start talking about what is legislation, how is it provided? Next slide. So this is the federal legislative process. The provincial processes aren't all that different. To develop legislation is an act of parliament, a law. To develop legislation, it starts almost anywhere. It could be a plank in the ruling party's platform. It could be something the prime minister wants done. It could be a legacy that the minister wants done. It could be something suggested by public servants as needing to be done. However it's initiated, it starts with a lot of background work, research, consultation, whatever is required for the particular issue. And then, generally speaking, there's a memorandum to cabinet written. This is a secret document. The public never sees these things. But what it does is it identifies the issue, it looks at all the factors affecting the issue, it looks at costs, it looks at options, it does an analysis of the options, and it makes a recommendation. Assuming cabinet has approved the recommendation in the memo to cabinet, it goes to the lawyers in the Department of Justice who transform it into some sort of bill, which is tabled for first reading in the House of Commons. It's debated, it goes to, perhaps it goes back to the justice lawyers for tweaking, then it goes to the House of Commons for second reading. Ultimately, it goes to the House for third reading. Assuming it's passed, then it goes to the other chamber, the Senate, where it goes through almost a similar process. Ultimately, when the Senate passes the bill, it goes to the Governor General for royal assent. And incidentally, the Governor General is Mary Simon, an Inuit lady. Next slide, please. Some laws have a provision to establish regulations. Regulations support laws, they are enforceable. They're not made explicitly by Parliament. The authority to make regulations is given by Parliament within the Act, but it's delegated to someone to establish the regulation. A perfect example, I think, in this context is what used to be called the Indian Health Regulations. These are regulations that were pursuant to the Indian Act. There was a provision in the Indian Act saying health regulations could be promulgated. The regulations were formed, I think it was in the 1940s. What they did was give authority to the Indian agent, a position that, of course, no longer exists, to apprehend persons walking around with communicable diseases. This was done at the time because tuberculosis especially was rampant, and it was felt that this was needed in order to stem the spread of tuberculosis. In the mid-'80s, when our Constitution was patriated, and when we got the Charter, it was determined that the Indian health regulations were contrary to the Charter of Rights and Freedoms. And so the government rescinded these regulations in the late 1990s, or I'm sorry, in the early 1990s. So legislation and regulations. Next slide, please. So, given legislation and regulations, what's policy and how's it developed? Next slide. Well, my starting point here, I went to the fount of all knowledge, Wikipedia, which said policy, a system of guidelines that give direction to decisions. Policy facilitates uniformity of outcomes. It's a statement of intent, and it's implemented as a procedure or protocol. Policy is a statement of what someone, perhaps the government, wants to do and how it will be done. A good example of policy, non-insured health benefits. As has been stated by previous speakers, the federal government considers non-insured health benefits to be based on policy. It has made the commitment to provide it. It is, according to the federal government, is not a legislative obligation, it is a policy, which means policies can be changed. That's policy. Next slide, please. There are different kinds of policy, clearly. There's administrative policy, human resource policy, finance policy, program policy. In government, there are different levels of policy. There's government-wide policy. For example, the government as a whole has said within its overall budget, the non-insured budget for this year will be X billions of dollars. There's policy at the Treasury Board level. One policy says anytime a public servant answers the phone, they must make an active offer to speak in either official language. There are departmental policies. When I was with Health Canada, the contents of the drug formulary, the non-insured health benefits drug formulary, were a matter of departmental policy. There is managerial policy. When I was regional director in Atlantic, I had a policy in place that any phone call from a client must be answered within 3 rings. It's only polite. So different kinds of policy, different levels of policy. Next slide, please. So why and how does policy get developed? Well, just as with legislation, it could be that the Prime Minister directs a minister to develop a policy. It could be the minister who directs the department to develop a policy. It could be the department who suggests to the minister that a policy be developed. Whatever the reason for initiating the process, as with legislation, there's background work to be done. There's research, perhaps consultation, depending on the nature of the policy, the size of the policy. It may be that it's important enough that a discussion paper is written. This will be similar to that memorandum to cabinet that I mentioned. A discussion paper will identify an issue. It will look at all the factors affecting the issue. It will look at costs. It might look at options. It might make a recommendation. Generally speaking, though, it does not make a recommendation. It's put out there just to engender a discussion among all the stakeholders. Now, the biggest example of a discussion paper is a white paper. Sometimes the government has a really big issue that's controversial, and it'll put it out for a debate in Canada in general as a white paper. It's done this with, if you recall back in I think it was the 80s, the frigate program, there was it was a very controversial issue. They put out a white paper, but also it was mentioned Chrétien's white paper and the response, the red paper. Yeah, those are ways of government getting input. Just following on the policy approval process, depending on how big, how important the policy issue, it may require a minister's approval. It may require a memorandum to cabinet. Probably it will require internal consultation within government, with the Privy Council Office, Prime Minister's Office, Treasury Board Secretariat, Finance, other interested departments, such as Indian Affairs, or what used to be Indian Affairs. I mentioned during the 80s, I was director of policy for what was the First Nation health branch at Health Canada. So I did this sort of thing for about a decade. Next slide, please. So what sort of First Nation health policy is out there? Well, there's probably more policies out there than I can mention or remember, but among the important ones, there's non-insured health benefits, as I mentioned. There's policy on capital. Under what conditions will the federal government build and staff a nursing station or a health center, or rebuild the nursing station or expand it? These are all matters of policy. There are policies supporting specific programs, building healthy communities, brighter futures, addictions programs, etc. All these are policy-based. The point was made by Louis, and I can reinforce it. The federal government does not consider that it has a legislative obligation to provide what it does provide. It's on the basis of policy. Next slide, please. There are, of course, gaps and weaknesses in the policy structure. It's not problem-free. Some of the important ones, at least in my view. Government policy on First Nation health does not take a holistic approach. We know from all sorts of research, including a magnificent paper put out by the World Health Organization under the United Nations, that the social determinants of health are really important. What WHO says is that just having hospitals and doctors and medications available will not necessarily make the community healthy. You need to look at the other social determinants of health. Social determinants include the state of the environment, the quality of housing, the availability of education and meaningful employment, all these things. And the one social determinant that I think people have overlooked that I think is very important is whether or not the youth in the community have hope for the future. I think that one's very important. As a result of not taking this holistic approach, government has tended to work in what people call silos. That is, the people doing economic development don't talk to the people doing housing, who don't talk to the people doing health, who don't talk to the people doing social development. As a result, people work at cross purposes. There's no synergistic approach to what they're doing. That needs to be addressed. Another issue, program development policies need much better alignment with culture of the people being served. Issues like cultural appropriateness, cultural safety are not being adequately addressed. A third problem area, of course, non-insured health benefits. For the 15 years when I was regional director, the one issue that gave me the most headaches on a day-to-day basis was non-insured health benefits. There are so many problems with it. If we take a step back, I would say that one of the fundamental problems with the policy regime in place, with the program regime in place, is that there's too much emphasis on treatment and not enough on prevention and health promotion. If more resources, more time and energy were put into the prevention side, less would be needed on the treatment side, and the quality of life and health of the people being served, I'm sure, would be much improved. Next slide. So what are the challenges for First Nation health service delivery? Well, it's already been mentioned, federal versus provincial jurisdiction. Louis mentioned the constitutional issue. I'll touch on that in just a second. Another issue is, of course, geography. There are a number of First Nations in remote and isolated areas, so they face a tremendous distance from hospitals. Quite often, mothers giving birth have to fly south, and so they don't have the social safety net that other people would have. Maybe that there's poor or no internet service up north, and so telehealth is a major problem. Also, we know that there's not enough health professionals where needed. It's very hard to convince doctors and nurses to work in the north. In fact, another of my big headaches as regional director, especially in Ontario, was recruiting enough trained nurses to work in nursing stations. At any given time in Ontario, I think about 20% of the nursing positions were filled by agency nurses. And this was a terrible thing because one, agency nurses simply don't have the vested interest in the community, and two, they're mostly not properly trained. As a result, they focus simply on treatment and ignore the public health side of their duties. So that's a problem that has to be addressed. Another issue, racial discrimination in the system. We know that's an issue. Joyce's principle is the epitome of this. Another issue, service delivery has to deal with the intergenerational impacts of residential schools and the need for reconciliation. This is, to me, blatantly obvious. And again, if we step back from everything happening, one of the big things that's missing is accountability back to the clients, to the people being served. You can't have a system where services are being delivered, but the people delivering them are really not accountable back to the people. It just doesn't work very well that way. So these are challenges that still need to be addressed. Next slide, please. Let's go on to the next one. Let's skip that one. So what are the differences between policy and legislation? Well, some of the key ones. A policy is fairly easy to change or update because it doesn't really have to go up very far in the food chain to get put in place. Legislation, on the other hand, is very difficult. It has to go through a legislative process. It goes to the House of Commons, to the Senate. Policy is not necessarily transparent. Government can change policy at many levels very easily. It doesn't have to make a big deal of it. Legislation, on the other hand, is very transparent. The media focus on what's happening in the House of Commons. Every word of every debate is captured in Hansard, which is available to anyone in Canada to read. So anything that goes through as legislation is very transparent. Policy, depending on its nature, may be enforceable in court. Legislation, on the other hand, is laws. They are enforceable in court. Laws are what courts deal with. First Nation policy is fairly amenable. Actually, it's quite amenable to First Nation political action. Given enough noise in the system, policies can be changed. Legislation is somewhat amenable to First Nation political action, bearing in mind that federal politicians, although I would hope they listen to First Nation leadership, also have to listen to other stakeholders. So what happens, happens. Next slide, please. So coming back to the constitutional issue, why is First Nation health service delivery so complicated? One of the issues here is the nature of Canada's Constitution. I think Louis mentioned that Section 9124 of the Constitution says the federal Parliament has exclusive authority to legislate with respect to, quote, Indians and lands reserved for Indians. That means that provinces cannot pass a law that's specifically about First Nation people or First Nation lands. They're not, they don't have the power to do that. Provinces, on the other hand, under Section 92.7 of the Constitution, have exclusive authority to legislate with respect to, quote, the establishment, maintenance, and management of hospitals, asylums, charities, and eleemosynary institutions. What this has come to mean is that provinces have the exclusive legislative authority with respect to health systems, health services. Now, you can see the problem here. First Nation people, to some extent, live on reserves, on Indian lands. Provinces have responsibility for health services. The two don't mesh very well. As a result, the federal government has become directly involved in health service delivery for First Nation people, especially on First Nation lands. How do they do that? Because the federal government has almost unlimited spending authority. The federal government has a lot of money and it has chosen to spend money on health services delivery. Also, we know that the provinces are reluctant to go onto reserve to provide services. So we have a problem there. And that's why it's such a, from the perspective of me as a former regional director, it was a nightmare. Regardless, next slide, please. And the next one after that, we'll skip that. So health legislation in Canada. There is federal health legislation that does not directly regulate insured health services delivery. The feds have legislation with respect to drugs and medical services, medical devices, sorry. No new drug or no new medical device can be sold or made available in Canada until it has been approved by the Department of Health. That's a federal responsibility. And as I've already said, the feds have significant influence over health policy and national objectives because of its spending power. The provinces and territories, on the other hand, have responsibility for regulating hospitals, health facilities, doctors, administering health insurance plans, all these things. So there is a divide here. The chief vehicle by which the federal government, if you like, intrudes into health services delivery is the Canada Health Act. So next slide, please. The Canada Health Act is the centerpiece of Canada's health legislation. It establishes criteria and conditions for provinces to provide insured health services. It defines national standards. And it does this because it says, if you don't do these things, we won't give you the money. And overall, what it does is to ensure that all residents of Canada have a reasonable access to medically necessary insured services without direct charges. Now let's explore this further. Next slide, please. So there are 5 program criteria under the Canada Health Act. Public administration. That means provinces and territories cannot privatize the administration of health insurance plans. It must be a government function. They must be comprehensive. That is, they must include all medically necessary services. They must be universal. Insured health services must be available to all legitimate residents of a province. They must be portable. If you're a resident of Manitoba and you move to Alberta, your benefits must be portable between provinces. And the services, the benefits must be accessible. That is, provinces must make these services, must give people reasonable physical access to insured services. Now this one is a bit problematic because we know in the North and remote and isolated communities, people generally don't have reasonable physical access to hospitals and to doctors. So what's happened over decades is the federal government has put in place a large number of nursing stations manned by specially trained, in most cases, nurses who can provide services. And if something is needed, if medical services are needed beyond what a nurse, under the direct supervision of a physician, beyond what the nurse can provide, then the person is transported down south to a proper facility. These are the 5 program criteria under the Canada Health Act. Next slide. There are also 2 important provisions in the Canada Health Act. First, Canada Health Act stipulates that no additional charge for an insured health services can be made by a health professional. So if you or I go to visit a doctor, the doctor can't say that you owe me an additional $100 for this visit. That's forbidden. Also, it's not allowed that there be an additional charge for insured services other than extra billing. That's a little confusing, but what it means is if you go to a hospital and the hospital says, sure, you can have your operation and we'll look after you post-op, but here's a bill for $250 for the x-rays that we took. They're not allowed to do that either. Not if the province wants to maintain its federal funding. So those are the key provisions under the Canada Health Act. It's a very complicated act. You want to read it sometime. Next slide. Now, the Canada Health Act is federal legislation. There's all sorts of provincial legislation as well. One example, just so you can compare one to the other, is the Public Health Act of Manitoba, which creates a legislative framework for the province's public health programs. It gives the province the capacity to respond to public health emergencies, like, for example, COVID or years ago, SARS. It creates the possibility of health surveillance, disease injury prevention, population health assessments, immunization programs, all these public health things. Next slide. And the Public Health Act of Manitoba has a lot of regulations pursuant to the Act. There seems to be about 24. But the regulations cover everything from how dead bodies are to be handled to how swimming pools, public swimming pools, are to be maintained. It covers anything needed under the auspices of public health. That's provincial legislation, provincial regulations, as opposed to the federal legislation in place, the Canada Health Act. Okay, next slide. Next slide, we'll skip that one. So, what's missing in existing health legislation? Next slide. Well, three important things. As has been said a few times already, there is no legislative base covering federal First Nation health services. The federal position is it's provided on the basis of policy, but there's not a law that says the federal government must provide certain services. Why would this be useful? Well, for a lot of reasons. It could clarify roles and responsibilities, eligibility. It would be, as it says, an unambiguous commitment to deliver those services. And it could certainly clarify accountability and funding issues. A second issue is funding mechanisms. Well, it's already been said that contribution agreements are in place, and some of them work quite well, but there are a lot of problems with contribution agreements as a funding mechanism. There are still quite a few contribution agreements that have to be renewed on a year-to-year basis. And to get it renewed, to get the funding to continue to flow, generally you need an audit at the end of the year. And sometimes audits are delayed. And if an audit is delayed, that may delay the funding. If the funding is delayed, it may delay the program. And then the people being served suffer. A third issue is lack of support for local service delivery. An unfortunate fact is there are a lot of First Nations in Canada with small populations, less than 500. Given a small population, it may be that they either don't have the sufficient people in the community or sufficient expertise in the community to fulfill all the requirements of contribution agreements. They may need help. Legislation could address this. How, you might ask? Well, let's look at the next slide. Some of the things that federal legislation potentially could do, it could create a statutory funding obligation. That means a legal obligation, which would replace annual appropriations in current contribution agreements. If you've noticed in your contribution agreements, generally it says funding will be available subject to annual appropriations. So for some reason, Parliament does not vote the appropriations, or if it's stalled, well, there are mechanisms for dealing with stalled appropriations. But this makes it much more certain that funding will flow and potentially flow on a multi-year basis. Federal legislation could create certainty, eliminate confusion about programs and services, and it would help with long-term planning. It could set standards for delivery of services. It could potentially create health institutions with the capacity to assist smaller communities or communities in financial trouble. And it generally could very much clarify roles and responsibilities of the various parties. Okay, so this is general background. Now let's get on to what ISC, the Indigenous Services Canada folks, are proposing with the current legislation. Next slide.
Oh, Mr. Chair, it's a 5-minute warning, so 5 more minutes to conclude your presentation, then we're going to go to Q&A with our co-facilitator.
Thank you. Okay, so the federal government has said they have certain objectives for the co-development of distinctions-based Indigenous health legislation. They want to establish some overarching, next slide. They want to establish some overarching principles. They want to support transformation of health service delivery on a collaborative basis. And they want to use this to advance Canada's commitment to reconciliation and fostering the government-to-government relationship. Next slide. So let's look at what these terms mean. Co-development. is simply a collaborative approach that acknowledges the distinct nature of First Nations, Inuit, and Métis. It's collaborative. That's what co-development is. Next slide. Distinctions-based. This acknowledges that constitutionally, Canada recognizes that there are 3 Indigenous peoples, First Nations, Métis, and Inuit. And it's finally come to realize that no longer can it take a pan-Aboriginal or one-size-fits-all or cookie-cutter approach to policy and programs. Each group's First Nations, Métis, and Inuit have their own needs and their own desires, and these have to be addressed individually. Next slide. The co-development approach that ISK is putting forward is guided by TRC's call to action, UNDRIP, United Nations Declaration on the Rights of Indigenous People, what's coming out of the National Inquiry into Missing and Murdered Indigenous Women and Girls, and general principles governing Canada's relationship with Indigenous peoples. These are kind of in the back of mind. Next slide. Co-development, the government has said, should happen in 2 stages. First, engagement, and second, co-development. Engagement means the government is trying to work with First Nations, Inuit, and Métis, with the provinces and territories, with subject matter experts, and anyone else to develop pathways towards co-development. Co-development then would happen together to develop the options for legislation. Next slide. ISK has identified a number of principles. Engagement will be inclusive, it will be Indigenous-led, it will take place multilaterally, but what's important, engagement, they recognize, is not endorsement. You can engage in the process without agreeing to what comes out the other end. You're not stuck with it, you can opt out. Also, engagement is not co-development. Engagement is the process of figuring out what everyone wants, acknowledging that there will be differences of opinion. Co-development is the next stage after you've identified where people want this to go. ISK has said that engagement will happen honoring the 2 principles of UNDRIP, sections 18 and 19. Next slide. And these are, Indigenous peoples have the right to participate in decision-making in matters which affect their rights. And Article 19 states shall consult and cooperate in good faith with the Indigenous peoples concerned through their own representative institutions. ISK has made that commitment. Okay, now, next slide and last slide. The AFN has made some statements on this process already, and the reference is at the bottom of the slide if you want to look into it. AFN recognizes that there are several feasible options. There could be legislation that creates a First Nation healthcare law regime applying to all First Nations, or there could be legislation that allows individual First Nations to adopt their own healthcare law. Basically, these are the 2 logical possibilities, so it's open. They also recognize that given this, non-insured may take on a whole new form. Fair enough. But they also throw out the warning that before decisions can be made, an awful lot more research and consultation must be done to figure out what you want and where it should be going. And then we go to the last slide, and I'm done. Questions? Back to
Do you have any
you,
questions
Mr.
online?
Chairperson.
Any questions in the room? Seeing no questions, Al, we thank you for your presentation, but we're going to have some reflections from our co-facilitator, Chief Derek Niepenak, on your presentation. Chief? Oh, we got questions. Oh, sorry, I didn't see you. We got a question in the room here, Al.
Okay.
Hi, Al. It's Ardell Cochran. I know I've been working with you on this file, and thank you very much. I just have one question. Are you
Sure.
aware of any process, whether court decision, where provinces did not provide medically required services or services under the accessibility to the insured services. Has there ever been any court case that took a province to court? I'm going to take, for example, ambulance services, which is an insured service, and if a First Nation took that on but weren't funded the same that other municipalities or jurisdictions in the province were funded.
Yeah.
Is there
Ardell,
any?
Sorry. Okay, Ardell, I'm not aware of whether any of these situations have gone to court. What I am aware of is there were a number of instances where provinces have at least put on the table their interest in looking at extra billing and co-payments, that sort of thing. And I know in those cases, the federal government, Health Canada, came down really hard on them and negotiated them away from that approach. But no, I'm not aware of any specific court cases as you suggested.
Okay, thanks. I just have a community that's fighting with the province to receive core funding for ambulatory services, and they have been unsuccessful, and the provincial government is saying it's a federal responsibility. But when you look at the Canada Health Act, they receive federal transfer payments for that service.
Yeah, and that comes under that thing that I said about the nightmare of the almost opposing parts of our Constitution, where feds have responsibility on reserve, the provinces have general responsibility for health, and it's never been really clearly resolved. It's still an ongoing headache.
Okay, thank you.
Right on, Ardell. Thanks for the good question. So at this time, we're going to take it over to Chief Derek Nepanak, reflections on the presentation. Chief.
Thanks, Willie. I just want to thank Al for a very thorough overview of policy, regulation, and law in the current state of the legislative regimes, both federally and provincially, and the great challenges that we face. And those great challenges that are represented on paper here actually translate into some of the tragedies and poor health outcomes that we see in the communities. I think that there's obviously the gaps that Al's identified, an opportunity with the discussion around legislation to address a lot of those gaps and to bring forward solutions that are focused on the truths and the realities that we face as Indigenous people in our communities. And I'm hopeful that, you know, when we do get to that stage, that there's a lot of focus on capacity building at the community level, and that is, you know, to train and educate more doctors, some more nurses, but also to ensure that that training is much more comprehensive in scale than purely a Western medical education, incorporating, you know, of course, traditional medicines and ways of seeking well-being within an Indigenous lens. So that's all I have for now. I think, like I said, it's a very comprehensive presentation. We're lucky to have Al, with all of his experience, providing us with that context to this discussion, because it certainly takes us to a more enriched consideration as we move forward. Miigwech.
Right on, Chief. Thank you. Thank you, Al, for your presentation. If you're still online, but for those delegates that are online, we encourage you to stay online. Stay online during lunchtime. We're going to reconvene at 1 o'clock for a few presentations. Presentation on Canadian constitutional and legal background consideration. That's going to be done by Paul Chartrand. You know, everybody knows Paul. You know, long-time lawyer. And he's also going to do a presentation on proposed principles and recommendations, and we're going to have the discussion after Paul's presentation. So at this time, we're going to go into lunch break. We're going to reconvene at 1 o'clock. So it's 12 o'clock, 1 o'clock. So see you guys at 1, and those people are online. We're encouraging you to stay online and join us again at 1 p.m. There you go, sir. Enjoy lunch. Just going to do a summary of this morning. And for those people that to just join on this afternoon, my name is Willie Moore from this Jossie Cree Nation. I'll be your chair for the next few days. We're blessed with the opening prayer from our delegate, Elder Doris Bear from Peguis First Nation. She led us off in a good way. And we had opening remarks from our lead facilitator, Chief Darren Nipanak of the Pine Creek First Nation. And we had the presentation on proposed Indigenous health legislation that was done by Mary Jane Armstrong of FNHSSM. She's the privacy officer and legal assistant. Did the background, why we are gathered here for the seminar, and the FNHSSM approach and mandate. And that led us to a presentation that was done by Louis Harper. Did the presentation on history of First Nations health legislation, development, and policies. Then we had a presentation on introduction of health legislation policy. That was from Al Garman. Listening to Al's presentation, and it was retired civil servant, and it was Atlantic RDG, and he started within the department. It was called medical services. So, did a well-detailed presentation. And again, the presentation is going to be made available from FNHSSM just through via email. You can contact one of the staff. They'll be more than willing to help you. And we had a lunch break. So that brings us to our afternoon portion of on the agenda. So this afternoon, before we get started, I just want to go through the agenda for this afternoon. The presentation is going to be on Canadian constitutional and legal background considerations. It's going to be done by long-time Indigenous lawyer, Indigenous rights advocate, Mr. Paul Chartrand, and 4 points to his presentation. It's all A, Constitution Act 1867, 1982, Indian Act, and international standards for guide the co-development of federal legislation and policy bodies, the recommendations. And after that presentation, we're going to go to a Q&A with our lead facilitator, Chief Derek Nipanak. And we're going to go right into another presentation from Paul on proposed principles and recommendations. And after that presentation, we're going to have discussion. And I'll have closing remarks from Chief Nipanak, and that'll conclude day one. So again, for our guests that have just joined us online, we are here live at the Club Regent Hotel. Delegates in attendance, the FNHSSM staff, and lead facilitator, Chief Derek Nipanak of Pine Creek, and myself, Willie Moore from this Jossie Cree Nation. So without further ado, we're going to get right into it. Our next presenter, as mentioned before, Mr. Paul Chartrand, longtime Indigenous lawyer, Indigenous rights advocate. But before Paul starts his presentation, I'm going to request Paul if you do a quick little summary bio of yourself, and also during your presentation for our IT team here, when he's give him a heads up for next slide, because we do have an amended presentation on your slideshow. So if you can do that, so this time, Mr. Paul Chartrand, the floor is yours.
Miigwech, Kiritomhin, thank you very much. The only thing I will add to your kind remarks is that I've had significant involvement with policy matters over the years. I have been a member of a federal Royal Commission that advised the federal government on all Aboriginal issues, and I've been a member of a provincial commission, a policy commission in Manitoba that advised the Manitoba government, and I can say that the Manitoba government accepted every one of the recommendations that were made, and I've also taught courses at university in law and policy respecting Aboriginal people. I want to start by saying, Miigwech, thank you to FNHSSM and all the people involved here. It's a real privilege to participate in this very interesting enterprise by FNHSSM. And I hope, as you have, Mr. Chairman, that we will overcome the small challenges of long distance communication, which we are all compelled to suffer these days, starting with COVID, but carrying on. But at the same time, we find advantages to that as well. So greetings to everyone in Manitoba, and greetings in particular to my relatives from my home community of Chartrand, and also to my other relatives in Pine Creek First Nation and the surrounding regions out there. So I hope everyone is well. So, and I hope that this afternoon also will go well, dealing with the topics that the chairman has just introduced. Allow me to start by explaining the use of terms. Words have no inherent meanings. The words have the meaning that we agree they have. So when we're dealing with law and policy pertaining to treaty nations in Manitoba, we are faced with a history of use of certain words. And so we have the word Indian, we have the word First Nation, for example. So I will use those words when they make more sense of what is being said. We have another word that is very important, and that is a general word, that is Aboriginal. That is a word that we find in the Constitution of Canada, where it recognizes and guarantees the treaty rights and the other Aboriginal rights of the Aboriginal peoples. Aboriginal, of course, from the Latin, ab, from, and then original, beginning. So from the beginning, in other words, the First Nations. That is the constitutional term. So it's appropriate to use it when talking about the Constitution. There is another term that has now been used because of a mysterious shift that I see in the use of language by people that I never understand where it comes from. But more recently, people have taken to using the word Indigenous, which can cause some confusion, because then the question is, are you referring to the Aboriginal peoples in the Constitution, or who are you referring to? The word Indigenous, has a dictionary meaning, but as far as its relationship to the original peoples of various homelands around the world, there's no agreed meaning. So there's a lot of ambiguity, but we should, whenever inquiring into important things, keep an open mind about the inherent ambiguity of everything. So there it is. I start by emphasizing the mandate of FNHSSM. FNHSSM can do what is within its mandate. And when we look at the first slide here, we see that the business of FNHSSM is based on the recognition of the treaties. This is why it's not legitimate in conducting work on behalf of the FNHSSM to ignore the treaty relationship. More will be said about that later on. And obviously, as you can see here, the work that we are engaged in today is work of a kind that is aimed to promote and increase participation of Manitoba First Nations in the control and delivery of health, and promotes understanding. So that's what we hope to do this afternoon, is to promote some understanding, and that's what I hope to make a small contribution to that as well. So if we may go to the second slide, let me start by saying that Al has already done a good job in setting out some of the possible options that we might find in a federal health statute if the government completes this process by adopting some federal health legislation pertaining to First Nations. But we don't know what will be in it. We have some idea from previous legislation, Bill C-92, for example, on child and family services that was recently enacted. So when we look at that history, what we should expect is everything will not necessarily go smoothly. C-92 has been challenged in court by the province of Quebec, and it's on appeal to the Supreme Court of Canada. So nothing is certain. Nothing is well known. We are dealing with ambiguity. So participation and discussion here will suit best those people who recognize and understand uncertainty and ambiguity. Those people who see things more in black and white and certainty, that's going to be a bit of a challenge. All right. Let's look at the standards and that limit what Canada can do in federal health legislation. What can Canada do? Well, the overriding question, I would say, for treaty nations in Manitoba, what's the really big issue? The really big issue, I think, concerns who makes decisions. Who makes the decisions that matter in regards to the health and well-being of treaty nations? So when we look at the Constitution, right, so we're looking at the Constitution of Canada and what it says, what it provides, that's helpful to get us to understand the situation of treaty nations in the province and possible federal health legislation. I think it's useful to start by thinking about, well, who has made these decisions? Decisions about the health of a people are made somewhere. Now, many people will agree with the idea of answering the question to who knows best. Who knows best what is good for them? Is the people themselves, or is it other people? So if we look at the Constitution of Canada, what we find is that the original Constitution in 1867 had no room for the treaty nations. In other words, there was no process there to say the treaty nations shall be in charge of deciding what is good for them. We didn't see any of that. So everything then has been done by strangers, has been done by outsiders. So you see there's a fundamental problem. If you agree with the idea that the best people who know what's best for them is the people themselves. All right. So let's look more particularly now at the authority of the government. If some of you are old enough, you may remember when you went to school that you were told that the government could pass any laws that it wanted. There was an old saying, if the government passes a law, it can say that day is night and night is day. And so as a matter of law, that's the way it is. It's no longer like that. There are limits to parliamentary sovereignty. There are limits to what a government can legislate. Now, in 1982, there were very important changes to the Constitution of Canada. The changes said that provided that the Aboriginal peoples mattered and that the governments in Canada were not to be allowed to do damage to Aboriginal rights and to treaty rights of the Aboriginal peoples, which includes the treaty nations in Manitoba. Now, who's that? Who are these people? And what are their rights? Well, that was to be decided by the political representatives of Canada and of the treaty nations. And so there were national First Ministers meetings on that. And I participated behind closed doors in that process. Nothing came of it. So the attempt then to create a constitution where the treaty nations would decide what's best for treaty nations It didn't occur to anybody in 1867, and in 1982 there was a process for it, but it didn't work. So what has happened? What has happened is now sometimes the courts have been asked, well, what's the law on this? What's our relationship between the treaty nations and Canada? Well, there are not many answers. So it will go ahead of where we're at to try to say that there are answers when there really are no really hard answers. So we're involved here. When we look at the Constitution of Canada and health, we're looking at a very ambiguous field. It's very foggy. We don't really know anything that is very certain. And when you think about it, you will appreciate that if the courts of Canada are going to decide the meaning of the treaties, well, that's not going to have a lot of support, because Canada is just one side of the treaties, and a treaty is necessarily between at least two parties. So if the courts of one side decide, that's not going to work very well either. So keep that in mind when you think about, well, let's resort to the courts. Say, well, yeah, but whose courts are these? So that's one of the very important issues that we should keep in mind. The division of powers. Canada is a federal system. Al and others have touched upon that earlier today. We have federal government and provincial governments. Well, what happened in 1867, as has been mentioned, is that there was an attempt to do something interesting in the Constitution, is to say, on this subject matter, the provinces will make laws. On that subject matter, it'll be the federal government. Now, that's a limited approach, because you can't foresee what will happen, how life will be organized. And the idea of being able to identify each and every issue that'll come up down the road as a subject matter that goes into A or B isn't going to work very well. In 1867, nobody thought that health was a subject for government to make laws about. And that's why you saw that very strange word that Al Garman showed you this morning, eleemosynary. In 1867, people thought that matters of health, medical care were matters for religious organizations, charitable organizations. And that's what eleemosynary refers to. And I suspect that for some of you, you've never seen this word before. So it's an 1867 type word which we don't use anymore. But there's the point, that some of the original constitutional features are no longer very, very good to help us to sort out how to think about federal health legislation. Before I go on to the next topic, I want to briefly mention the Indian Act, which is slide 3 here. And I simply want to draw to your attention the fact that in the Indian Act, the Indian bands have the authority to make bylaws under Section 81. So that is a possibility. I think that decisions should be made by those who have the authority to make those decisions with clear eyes. And so if you're making decisions, the better decisions are usually going to be the ones that take into consideration all your available options. And then it's up to you to decide which ones to take on. So one of the points then that's important is that as a band, bylaws may be made to regulate health. So you could do it under the Indian Act right now. And that bylaw power could be interpreted expansively. So action could be taken right away. Now, I go on to the next part, which is to look at international standards. Now, as I mentioned earlier, the government can't do what it wants. The government has limits on its authority to make laws, to make federal health legislation. Now, some of those are in the Constitution of Canada, but some of them are not. But they, nevertheless, they bind the government. Government has to respect them. And what I want to look at now are the standards that are called human rights standards. These standards have developed in recent decades only, mostly since the Second World War. And these standards apply to everybody, all the people that are human. So you can think of it as a way, we are now in a modern era where finally Indigenous people are regarded as belonging to the human race. No longer are Indigenous people looked upon as people where you could steal their lands willy-nilly because you could and get away with it. So now there are limitations that apply to all human beings, and these are called human rights. And relying on human rights has the value that is very hard for opponents to reject. If you reject human rights, you're saying, well, you're not humans. So it's a very important point, which is made in politics. All right. Now, the United Nations Declaration on the Rights of Indigenous People is being adopted according to legislation. It is not yet adopted, but what the government legislation now does is it says that we'll come up with a plan to do it. So it's in the future. But nevertheless, there is some value to that we can explore at some other time. The one point that I do want to make is that Supreme Court decisions of Canada's Supreme Court, has emphasized what I am going to say, that certain human rights that are part of international customary law are binding on Canada. So these are some of those complex matters that are not generally well known. But it is clear, particularly from a recent decision called the Nevson decision, that international customary law binds Canada, which means you can go to court on this. So if you pay attention to the next standards here, behind that point is this, that if the government in this process of working towards federal legislation doesn't do the right thing, you could at least, among other things, go to Canada's own courts and say, hey, we want you to declare that Canada is obligated to do the right thing. All right, so that's the significance of the international human rights. If we go to the next slide, Pete, please. Now, what I want to emphasize in this one is that the idea of a right to health is a very ambiguous thing. It wouldn't be practical to think that, oh, we know what that is, or anybody knows what that is. That's not the way the world works. It just doesn't work that way. Health, for example, is not really a subject matter, as we have seen. And no one can have a guarantee of health. Like if it means good health, it doesn't mean that. So what does it mean? Well, if the best source to find out what the world community thinks about what can be called a human right to health is in international customary law. And rather than give you all kinds of boring and complicated detail, I just mentioned that international customary law, the heart of it is found in what we can call a General Comment 2000. It's based on a human rights treaty. Canada signed that treaty. Canada is bound by that treaty. And that general comment represents international customary law that binds Canada. Therefore, the suggestion is that the government of Canada ought to adopt this as the general guide. Let me emphasize then, what's the right thing to do in this process, regardless of what the government calls it, co-engagement, consultations, whatever. When you're talking about the idea of passing federal health legislation in respect to Aboriginal people, your guidance should be the 2000 general comment. Next slide, please. So if we look, the comment is fairly lengthy, and I don't reproduce all of it here. I simply want to emphasize that it is very broad. The idea of a right to health is to be understood very broadly. And if we go to the next slide, we note that there are particular features of that human right that relate to Indigenous peoples. So briefly, we can say that the right to health, as understood in international human rights law, requires that what the state does be culturally appropriate, fit, make sense in light of the cultures of the Indigenous people. It must include traditional medicine and so on, and it must also involve and appreciate the relationship between individual health and the health of communities. And very important, it must also include consideration for the health of the environment. And we'll find that particularly in that next slide, slide 5, that the states parties who want to do the right thing have to consider all these features, including all the aspects of the environment. So the right of the environment, the health of the land is a part of the right to health. Think for a moment of the great wrong of Canada in a grassy narrows and mercury poisoning situation that will give you an instant appreciation of the significance of environmental health for the health of Indigenous people. If we go to the next slide. I mentioned that the current government has passed a law, a statute, sometimes called Bill C-15, that says we're going to make a plan, and in that plan we're going to figure out how to adopt the standards in the UN Declaration on the Rights of Indigenous Peoples. So when we look at that, we see a number of particularly important issues relating to health and social development. And we find them in Articles 20 to 25. And let me add here that social development is itself a human right. The human right to self-development is important. I don't have a particular slide on it, but you should remember that. The reason you don't hear much about the human right to development probably has to do with the fact you live in Canada. The right to development includes self-government, but it includes social, economic, political, cultural development. One reason I suspect that this is not a very popular idea in Canada is because Canada is regarded as a first world, a land of plenty. And development is regarded for developing countries, down to really, really poor countries. So it's not a good image for Canada to say, well, there are people in Canada who are like living in third world conditions or fourth world conditions. If you recall what the late George Manuel wrote in his groundbreaking book in the 1970s, The Fourth World. So this is important. Remember, in addition to the things that I'm introducing here, there's also the very important human right to development. But the human right to development is included in UNDRIP. So keep that in mind. Those relationships between the various sources of international standards are indeed very, very important. And a particularly important matter here is that Canada has legal obligations to create a national program. It's very important that the program for health be national and that it not be particularized and kept to small regions so that you can pursue a slice and dice or a divisionary approach to providing for rights to health. So here's some of the legislative provisions that mention that Canada is obligated to provide financial and other assistance to treaty nations. The next slide, please. When you have time, you can have a look, if you will, at the American Declaration of Indigenous People, which is not all that well known, in part because Canada has not formally adopted it. The Harper government rejected it. It didn't want to deal with it when it was adopted in 2015. But perhaps one good idea might be to put pressure on the current government and say, why are you not adopting the American Declaration on the Rights of Indigenous Peoples? Because when you look at it, you will see that it has particular features pertaining to health that are particularly important for Indigenous people. And I gave just one instance here in slide number 7. As we go on to number 8, please, which also deals with the American Declaration. And here is a particular focus on environmental health. And what does it mean, environmental health? That's a hard word to say, environment. If, like me, your first English is not your first language. All right, so Indigenous people have the right to the conservation, protection of the environment, and the productive capacity of their lands or territories and resources. So remember, all of these rights of Indigenous people are all connected to the right to health. So you see, the right to health idea is indeed a very broad vision of the place of Indigenous people in state Indigenous relations. Now, we conclude here number 9 by having a quick look at what some domestic policy bodies have said. Well, the Truth and Reconciliation Commission has said pretty well what I've just presented. It says we should recognize and implement the healthcare rights of Aboriginal people as identified in international law, constitutional law, and the treaties. And that's what I've just tried to review in a very inadequate and short period of time. And tomorrow we'll be looking particularly in more detail at the treaties. And final slide, please. And the Murdered and Missing Indigenous Women and Girls National Report also urged the adoption of international human rights standards and the improvement of health systems. And sorry, not finally, the 11th slide, please. A commission of which I was a member also proposed a comprehensive analysis focusing on the actual practical problems facing First Nations in receiving and benefiting from any state programs, and proposed the creation of healing centers to coordinate services, noting the challenges to First Nations with all the variety of institutions that existed now, as well as healing lodges on reserve to provide residential care. And most important, and I note that this was mentioned by a previous speaker today, that there's a tremendous need. There was in '96, and there's still continuing a really significant need to train professional and administrative personnel. And I would suggest that certainly applies to the Treaty Nations in Manitoba, but I would suggest it also applies to the government side of things as well. So, there we are, and I think that's the end of it. I'm looking at all the various things here. That's the end of that presentation, Mr. Chairman. And I'm looking at the agenda. I will wait for your instructions, but I believe that I'm also being asked an hour or a bit later to speak on the principles and recommendations, which will come back again tomorrow. But I stop there and wait for your review and instructions. Miigwech.
Right on. Thank you, Paul. Good presentation. Again, we're going to go into reflection with the Chief Derek Nepanak based on Paul's presentation. And after Chief Nepanak, then we're going to entertain questions online or on the floor. So, Chief Nepanak.
Miigwech. First off, I just wanted to provide a little personal reflection on the early days of exploring an Indian Health Act. I knew that, at the time, the Assembly was looking at building a capacity in this discussion, and we thought, who are we going to get to help us out in the process? Because we we got good people internally, but where are we going to find that capacity to go into the deeper layers of policy and Canadian constitutional law to see where we fit this discussion into? And of course, Paul Chartrand was considered and still is considered, to be one of the preeminent thinkers and speakers on the issue of Canadian constitutional law as it relates to Indigenous people. So we brought him on board, and we spent a lot of time talking about this stuff early on, and he introduced other brilliant minds into the conversation, and we benefited from that at the time, and we continue to benefit from that. What I think this does is it brings us to the tip of the spear. I think that we are the cutting edge thinkers in this space here in Manitoba, here within our discussion table, because we brought, I think, the smartest people that can understand the nuances and the ebb and flow of different political, provincial, and federal processes to light for us. And case in point, just Paul's presentation here and touching on so many different complex matters of domestic and international law in 45 minutes shows us that we have the right people that are able to engage this very lofty agenda. I'm, as always, very grateful to have him join us in a conversation and to provide the perspective we need to move this forward. What he's basically done is he's taken, I believe, the toolkit, and he's unpacked it for us to show us what are the various tools we have in our disposal to help craft the types of solutions that we need for our communities. And this is going to come in handy as we get into the deeper conversations around engagement and the actual development of the legislation. So, miigwech.
Right on, Chief. Paul, any comments for Chief Neepanak? Have any comments, any questions on the floor, online? Paul, you still there?
Is he still online, or is he?
Is it my turn now, or?
Hey, Paul, there you are. Yeah, so just any comments, additional comments, just based from Chief Neepanak's reflections? Anything you need to add before you go into your next presentation?
Are there any questions from the floor?
So no questions on the floor. Online, any questions for Paul? Questions for Chief Neepanak? None? No questions. So Paul, so I don't know if you want to add any more comments for Chief Neepanak based on his reflections, or you want to go right into your second presentations, the principles and recommendations?
Thank you, Mr. Chairman. I appreciate very deeply the remarks of Chief Neepanak and his participation and contributions to this process. I know will be invaluable to the FNHSSM and the Treaty Nations in Manitoba as this process goes on. Miigwech, thank you very much. On your instructions, Mr. Chairman, I will be prepared to make my presentation to be followed by discussion. I'll be able to be prepared to make my summary presentation anytime you wish on the principles and recommendations.
Thank you, Paul. So again, the floor is yours. So second component to Paul's presentation this afternoon, the principles and recommendations. So just another heads up, Paul, for the for our IT team, just give them a heads up for any switching slides.
Okay, am I on now, Mr. Chairman?
Yep, you're clear, live. We're gonna take it
Okay.
over. Mic number 2, all the way from St. Lorette, Mr. Paul Chartrand.
This is, the small technological challenges of long distance seminars. I tell people I never really know exactly what I'm doing with the technology. I'm still getting over the shock of the invention of the fax machine here, and people sometimes expect me to do all these very complicated things. So thank you for your advice as we proceed here. So the next topic that I present on now is a summary of principles and recommendations for the process and for the federal legislation. This, I suppose, should be the result of the research discussions that are being done and promoted by the FNHSSM. And so here we have again the mandate of the FNHSSM that we mentioned before. The mandate says we must pay attention to the treaty and inherent right to health. They're culturally appropriate, holistic, and community-based, and to develop strategies and initiatives and increase the participation of Manitoba First Nations in the control and delivery of health, and so on. So, allow me to begin by giving you a very brief summary that will include everything else that I will propose to say this afternoon. I noticed that the agenda has included this initial discussion of principles and recommendations for the federal health legislation for treaty nations. I think there's wisdom behind that because this is the ultimate product, I suppose, to come from the process that we're engaged in, that the FNHSSM is engaged in, and that all of you in the audience are engaged with. So presenting that today should give everyone an opportunity to ask questions, to talk about, to think about what principles should guide us and what recommendations should be made to the government by the treaty nations in Manitoba. These are not simple questions, and I am not at all aiming to be prescriptive, to say this is what you should do. No, I don't do that, and I don't say that. What I am proposing is that here are some ideas to think about. What do you think about them? What are better ones? Which ones do you think have little merit and we shouldn't carry on? So this is the very short summary. Let me say first, well, what are the principles? What are they for? Why do we need principles? Well, remember, this is about the state-indigenous relationship. Canada is a state, and the treaty nations in Manitoba are the Indigenous peoples. So this is a matter involving the state-indigenous relationship. And in looking at how to handle, to develop, to respect that relationship, principles are a good idea. Principles are values and ideas that should guide the actions of people. Why? Because we want, among other things, to avoid arbitrariness. We don't want people to come on and say, well, we should put this in the legislation. And the answer is, well, because my cousin over there thinks that would be good. Well, okay, that's good. That's a personal opinion. But it could be that government people, on the other hand, might decide, well, we're going to do it this way. Why? Because it saves money, or for what other purposes, political reasons and so on. But these can be called arbitrary decisions. Principles appeal to generally acceptable ideas of what's the right thing to do. That's what principles are for. They're to avoid arbitrary decision making. And you'll remember Al Garman talking this morning about policy and the difference between policy and legislation. So policy can be influenced by arbitrariness, but you would hope that legislation is not. That legislation following democratic, very widely accepted principles should not be arbitrary, but they should be principled in that they should be defensible and they should be based on broadly accepted ideas, ideals, and standards, and so on. So that's the reason for the principles. And so the principles are presented here in brief, and then they're followed by the recommendations. And it is proposed that the recommendations also accord with the principles. So I will give you my summary first before we go on with the principle here, and I thank you for that slide, and it's quite appropriate for it to be there. But I want to say first, here are the 5 points that I will make about principles and recommendations. Parliamentary sovereignty is limited and bound by obligations from the Constitution and human rights standards. I mentioned that this morning. The second one, health has a broad meaning that includes individual and community health, as well as the health of the environment. The third one, special obligations to Indigenous people include respect for the treaties and for the cultures, including traditional practice and medicine, as well as funding and assistance in a national program. And next, fourth point, scale and costs must be weighed, as well as the administrative burden of a sectorial approach in small communities. And finally, Canadian federalism requires political commitment and cooperation. So that's the summary of what you're going to hear from me anyway today on principles and recommendations. And that would be repeated and expanded again tomorrow. And I think it's appropriate that the agenda be so structured, because I think ultimately this is what we're striving for, isn't it? To make sure that the decisions that are made are solid decisions that are made, and that in the end, the legislation is beneficial. All right. So here are the principles then that I suggest for your discussion and consideration. The principles will begin by recognizing what has come before. Where are we now? What has preceded this time in Canada? So we recognize that. It should be recognized that the federal and provincial governments have made unilateral decisions, that means by themselves, concerning the health and well-being of First Nations, whereby these governments have imposed their policies and laws on First Nations and the people who belong to them. And that is much the subject of the Wabung 1971 that Chief Nepinak mentioned and that Louis Harper mentioned this morning. And that's sort of the modern beginning of this political movement in which we now see in that movement the move towards federal health legislation. We recognize also, as a matter of principle, that the First Nations in Manitoba have not been allowed to participate in the processes of executive federalism that have generated intergovernmental accords that affect their health and well-being, including the social and health transfer accords. And this is one of the things that were dealt with, some of the things that were dealt with this morning by Louis and Al, is that the treaty nations have not been involved in these processes until that is, the exception would be following the 1980s constitutional changes and some of the attempts and the continuing attempts of treaty nations to participate in Canadian federalism. So remember, one of the big underlying issues here is what's the role of treaty nations in making decisions about their own public interests in the Canadian federal system? Where does that belong? What are the institutions that we have to set up? So that's what that principle has in mind. In the next slide, please. And the second slide, of course, is also from taken directly from Wabong. The next two, these are quotations. This is a statement of the attachment to the land by the First Nations in Manitoba. This is the way it was expressed. Our attachment means that we must commit ourselves to help develop healthy societies for all the peoples who live upon the land. It's not a selfish approach. This is what the chief said in Wabong. But we will not be able to contribute unless we have the means first to develop a healthy society for ourselves. And here you see the significance of those international standards that were mentioned a little earlier. The government of Canada has a positive human rights obligation to do that, to provide the means. Since the signing of the treaties 100 years ago, in 71, we have been constantly and consistently prevented from doing so. And the next quotation is, we maintain that health services should be included in federal health legislation. There we go. Next slide, please. This principle would acknowledge the unfinished constitutional business of the 1980s that I mentioned previously. They failed to reach decisions on implementing the treaty relationship. And we should recognize that the idea of going to court to resolve the meaning of the treaties can never, in the long run, be legitimate, be acceptable to one side. The treaties involve two parties. How can it be fair that the courts of one party decide? So looking ahead, I say, as recommended by the RCAP in 96, Canada needs new institutions. It needs a new tribunal or a new court to be created that's fair. We must provide fairness in Canada for the state-Indigenous relationship. And when dealing with disputes on the meaning of the treaties, if practical negotiations run into problems, then the dispute can be put to a fair tribunal or a fair court, which means it has representation from both sides. This is the way treaty disputes are resolved between countries. You can bet that Canada wouldn't have it any other way in its treaties with the United States or with other parties. Emphasizing the principles and obligations in Canada's Constitution Act 82, particularly in sections 35, 35.1, 36, and the former section 37. I put that in there because it would take me a very long time to even review these. But the point is, it cannot be overemphasized. The complexity of the constitutional background to this cannot be overemphasized. All we can do is to try as best we can to offer you a little bit of a bird's eye view on these issues and to tell you, look, these are complex matters. And when we look at the recommendations later on, we have to think about that. How do we deal then with very complex, specialized matters? So keep that in mind. And the next one, emphasizing also that consent and the rule of law are fundamental features of the Constitution that apply to negotiations on treaty nation federal health legislation. Consent and the rule of law. So consent, again, leads to the idea that the people must have a way of saying, yes, we agree to that. Yes, we agree to that. And who can decide that? Yes, we agree to that. It's the people themselves. and the people themselves through the ways that they express their individual and collective views. And the rule of law means a couple of things, but it means that the law must be known. That's what the idea of the rule of law means. It means that the law must be known. And this is one of the unfortunate features of Canada that we see pop up every now and then, is that the law is simply not known. And where the law is not known, then the rule of law breaks down. That idea, the principle of the rule of law breaks down, because the law as it affects treaty nations is not as well known as the law that applies to other people. Next slide, please. We're still on the principles here. So affirming then that the process and final substance of federal treaty nation health legislation must reflect the highest standards of good faith, respect for self-determination, and compliance with all the human rights standards that bind Canada, and in particular be guided by the binding standards of international customary law that are outlined in the 2000 General Comment on the provisions of the ICESCR Treaty. That treaty is the International Covenant on Economic, Social, and Cultural Rights. Now you have a good idea of why we use shorthand and why I avoid as much as possible references to the long words that apply in discussions about international law. It's everything has a very, very long title. And finally, another principle, recognizing in striving for cost effectiveness that traditional medicine and practices reduce costs for healthcare. So that's some information that we have from professional people who deal with these issues. If I may ask then if we can go on now to the second part, that is recommendations. So what recommendations might follow from an adoption of these principles? So these are the recommendations that are open here for your discussion, for your consideration. What do you think about these recommendations? Do you think they have any merit? Do you think that they should be confined to the dustbin or the garbage can, as we say in Manitoba? Or if they have merit, what should we do about them? So the recommendations then refer particularly to the situation of treaty nations in Manitoba. And they derive from the perspective of FNHSSM. And if I have them wrong, then I apologize, and we will have plenty of time here for FNHSSM and other representatives to set the record straight and to say, here are the facts. And Chartrand, you've got those facts wrong. But the first one that I propose for consideration, discussion, is that the timetable be revised to set realistic guidelines. I don't expect for 1 minute that it is realistic to believe that a thoughtful review of the options, the possibilities for federal health legislation could possibly be achieved in the short time that's being set. I believe that the timetable is set like 2023 sometimes for actually drafting the legislation. In my respectful view, that's a real problem. More time is needed. Look at how historic, how important that is. Look at the fact that the treaty process is involved. We're not even at the beginning of having a defensible treaty process. How can we expect to have legislation done that respects the views of each side in such a short time? I cannot see it. But of course, this is an open discussion, and if somebody sees it, I'll be happy to hear it. And I suspect we'll all be happy to hear it. The second recommendation, that the process be rationalized. with federal plans for treaty implementation and fulfilling government Section 35 obligations. Now, let me explain the practical features of that. There's a process now, okay, for the government calls it co-engagement. Look behind words. The federal government plans federal health legislation. All right? The government plans to have discussions with FNHSSM, with treaty nations in the province. All right? We noticed that the federal government has obligations to implement the treaties. It's acknowledged that in policy statements. The government has also enacted what is called Bill C-15, which provides that Canada must implement the treaties. It means it must talk to people, talk to treaty representatives. Well, how does this process towards federal health legislation, how does that fit with that? Is that a part of it? Is it separate from it? If it's separate, why? And what about the Section 35 obligations? We know what the government has, among other things, something called the Recognition of Indigenous Rights and Self-Determination tables, about 100 of them, I believe, across Canada. So how does this process towards federal health legislation fit within those things? Or are there several processes for purportedly reaching decisions on the same subjects? Is that defensible? I think this has to be rationalized. That's the word I used here, that the process be rationalized so that we understand it. Perhaps some in the audience today will tell us. I approach the subject, with humility. It could be that someone here knows how this process for dealing with potential federal health legislation fits with treaty implementation plan, how it fits with this RIRSD project, because I don't know. 3, that the process, as well as a final program and legislation, must reflect the elements of the human rights standards that apply to Indigenous peoples. That's the General Comment 2000 that I mentioned, as well as the other international standards, including the American Declaration and the very important particular features that it mentions, particularly with regards to environment, prohibition against using Indigenous people as medical guinea pigs, and so on. And that require Canada to adopt a national framework. These are 2 of the really important features of those human rights standards. That it must be a national framework. I believe that's what the government proposes, but the national means it's not provincial, it's not regional, it's not local. It applies generally as a framework. And also provide funding assistance, and also provides other assistance. I note that the field of providing medical care and health services to people anywhere is very complex. FNHSSM will be very fortunate in hearing from a world-renowned expert tomorrow, Professor Tui, on the different kinds of systems, institutions that exist around the world to deliver healthcare services. So we look forward to that as well. So I think a very important part of the recommendations should have to do with the question, how is the best expertise which treaty nations deserve? How is the best expertise put to use to offer the best solutions? How can that be done in such a short space of time? Perhaps what we have to think about is creating permanent institutions to provide those kinds of services and assistance. And number 4, that federal legislation and protect and promote traditional medicine and healing practices. And my understanding, which is an amateur understanding, is that there are some adoptions of traditional medicine and healing practices in Western Canada, including, as I understand it, in Fort Capel and in Edmonton. But I would like to learn more about this. I'm also aware of initiatives in Australia that have been successful in integrating traditional medicine and healing practices with very good positive results according to all sides. Do we have it? And yes, next, one more slide. We have 7 altogether. And number 5, that the standards derived from the owner of the crown. What's the owner of the crown? The owner of the crown is an idea. It's an idea developed by Canada's courts. So we're not responsible for it. So the courts of Canada invented something they call the owner of the crown. It's not a right, but it's the idea that the crown must do the right thing when it deals with treaty nations. So I always think perhaps that might be a helpful way to think about it. Whenever you're dealing with government agents must do the right thing. What's the right thing? It depends on the circumstances. That's what the courts have said. But you have to do the right thing. So it's a general idea. So the general idea here is that there are 2 departments now that deal with the relationship between Canada and the treaty nations. One of them presumably has the job of looking after the Indian Act and the continuation of that federal control through the Indian Act. That is ISC. And the other department, CERNAC, Crown Relations, has the mandate to turn the page, to engage in new relationships with the treaty nations, including to negotiate and implement the treaty relationship. So what we see at the moment is that it is ISC, the Indian Act Department, that is in charge of what it calls co-engagement on federal health legislation. Well, what does that mean for treaties and the so-called treaty right to health? If the discussions have to do with the existing state of things. The existing state of things represented by ISC is citizenship rights. To improve the Indian Act, the idea, which is expressed in a common expression called closing the gaps, is to deal with the rights of all citizens. So treaty nation people are also citizens of Canada as a matter of Canadian law. And as a matter of Canadian law, all treaty nation people are entitled to all the rights, benefits, and burdens of Canadian citizenship. Because the statistics show a gap in achievement of educational achievement, health results, and so on. It's called closing the gap, but that's equal citizenship. So ISC is equal citizenship. CERNAC is treaty rights, something different. You don't have the benefit of treaty rights unless you belong to a treaty nation. So dealing with citizenship rights is a good thing, but it fails to deal with the treaty relationship. And that's the issue in number 5. Number 6, that the approach recommended by the federal RCAP in '96 be considered. Our commission spent much time and energy and retaining the advice of experts in the health field, held consultations across Canada, and came up with a comprehensive look at the field of health and made a range of recommendations including a national strategy, which is part of the obligations of Canada to come up with this national strategy. And most important, it recommended a concerted strategy on administrative capacity and training, which I'm not aware that has ever been implemented. And so this is one of the huge challenges as to if a health system is going to be created that's new in objective and in design, it needs specialized handling. It needs the capacity of people who have the requisite expertise, whether they be physicians, surgeons, or clerks, nurses, or other administrators. And remember that Canada is not a world leader in the administration of health services. From my examination of the issue, Canada usually ranks around 30th or worse in the world in the delivery of medical care and healing services. I don't think that's something to be very proud of. And the matter is not money. Canada spends as much as some other nations that are far ahead of Canada in producing good results. So there's a question there that should be addressed. So this is a very important debate in Canada, and I think that important debate should be a part of the reflection on what should this federal health legislation deal with. And I think these are the matter of administrative capacity and training should be dealt with. I don't know how the federal government is organized. What is its administrative capacity in regards to that? So on to the last number 7, that consideration be given to the creation of new national institutions to provide help on the design and implementation of local healthcare institutions and processes. So what I'm proposing here is that we're dealing with, what do we do? I think one of the things that should be considered is to create new institutions. I think that was one of the points mentioned this morning by Al Garman. You have to have new institutions because there's new undertakings. If treaty nations are going to undertake new roles, provide new things that have not been provided before, that has to be done systematically according to a known way of doing, and we must understand the requirements of those institutions. For example, we have local boards, physicians organizations, hospital organizations, and so on. How are these going to be organized? And we know that little groups, little communities don't have the same capacity as very large ones. So that's one of the questions of scale and cost that have to be considered. All very, very complicated. And what I've aimed to do is to provide you with a very, very loose and general outline, which I hope I'll be happy if it contributes a little bit to a good concerted discussion today and tomorrow and produces some success for FNHSSM, for all the participants here and for the treaty nations in Manitoba. Mr. Chairman, that concludes my presentation. Miigwech.
Right on, Paul. Again, we thank you for your presentation, well detailed, well prepared. I wouldn't mind sitting around a campfire with you, man. Well knowledgeable in many areas. So at this time, we're going to take any questions. Any questions for Paul on the floor? There's none online. If there's no questions, then we're going to go right into the discussion. Okay, well, so having no questions, we got a recommendation here. Chief Nipanak wants to take a 10-minute break before his presentation. So before we let Paul go, no more questions? But
I'll be staying later.
yeah, okay. We're going to recommend you stay on. Yep. So we're going to take a 10-minute break. 20 after 2. We'll reconvene at 2:30. for a final presentation for the day, and that's going to be on principles and recommendations. It may more of a discussion that's going to be facilitated by Chief Derek Niepenek. Alrighty, welcome back. So for our final presentation today, so principles and recommendations, more of a discussion that's going to be facilitated and led by Chief Niepenek. So, and then closing remarks after his presentation. So we'll just do both of them all two in one. So at this time, I'll take the floor for Chief Niepenek.
Miigwech, thank you. I found the information today to be all very, very comprehensive for one, but also very interesting in terms of the options and the opportunities ahead of us. I wonder, you know, in terms of the participation, the levels of political participation are going to factor in at some point. Before I speak about the principles and recommendations that have been discussed, I just wanted to talk a little bit about the politics. And I can speak about the politics because I'm a chief, I'm an elected politician and community leader, and I think it's important that we spend a bit of time talking about politics now and again, because there's always a lot of different political agendas, I guess, that you can say that are influencing, you know, the processes and the discussions that are happening throughout our territories. And in Manitoba, we have, you know, I think three political organizations. You've got obviously AMC, MKO, and SCO, and then you've got an AFN regional office as well. I understand there's also a couple of grand chiefs that have been elected out of the tribal councils as well. So those tribal councils are politicizing their administrative support mechanisms at the tribal council level, which I guess is a way to politicize and help ramp up the political discussions in those respective territories. And that's all fine. But at some point, there has to be commitments to unity and unification. And I reflect upon 2011 when we went to Lake of the Woods and we engaged in ceremony, and we came out with what we called the Unity Accord. All three political organizations, including facilitation by then regional chief, the late Bill Travers. Three organizations came together, and I, as Grand Chief at the AMC, gifted the Grand Chiefs of the other two organizations, and we agreed upon working best practices within designated spaces, and that we wouldn't overlap with agendas, and that we would stay out of each other's lanes on specific and important issues. And I thought that, you know, we carried a significant capacity at the AMC with a lot of our most skilled and brilliant trained administrators and policy thinkers. And we undertook at that point the health mandate. You know, that led to the creation of the First Nations Health and Social Secretariat of Manitoba, and I think it paved the way for some very significant work that could have happened, you know, through FNHSSM, and which has happened. But at the same time, we also see, you know, a new government come in recent years and sprinkle more money around, you know, under different political mandates, whether that's at MKO or SCO, to do what they call health transformation, or basically to engage the administrative mechanism of health authorities and to act as if that is a transformational change in health. I don't know if that's the case or not. I haven't seen, you know, the effects of health transformation agendas at the other two political organizations. But, you know, all the best to those processes. What we're involved in here really is a broader discussion that actually incorporates moving beyond health regulation and policy and into the space of legislation, as has been laid out very, very detailed here. And I think that we have to call for a unifying message to be carried to the organizations, all three, to rally around this opportunity, to set aside different political agendas and to move as one as we seek to have a real thorough discussion. Excuse me. So with that in mind, I recall the ceremonies, the sharing of the pipe, the sharing of the Bible passages that were shared, the mix of our spiritual ways of connecting at the time to bring us back to those days and to help us move forward in a respectful and a good way with a clear mind and a good heart for the discussion. As had been mentioned in Paul's last presentation, he went in very, very thorough detail around principles and recommendations. And I think everybody has a copy of those principles and recommendations as they've been laid out very, very clearly. I'm not going to go over that much with respect to the specific items, but there was a couple of places where I thought it was important to make a point or two. Of course, once again, reiterating that in 1971, so how many years ago is that? That's almost 60 years ago now, or 50 some years ago. We maintain health services should be included in federal health legislation respecting the rights of Indians. So, as I said earlier on, this is something that demonstrates that, we've been calling for, a federal certainty in terms of how health services are provided to our people since, the early chiefs came together under what was then the Manitoba Indian Brotherhood. That principle is so entrenched that it survived into 2022 here, and it will survive as we continue to push forward. We cannot say that, this push for federal legislation is just the flavor of the day because it's a Liberal government that wants to put money into it. This is something that we as people have carried as a message since the time of our great-grandparents, and in some cases great-great-grandparents, and probably even further back in time than that. And these were the chiefs that lived treaty every day. So you can have treaty, you can live your treaty, but you can also hold Canadian governments accountable by demanding proper legislations in place to protect the rights of Indigenous people. And I think that's a very important point to make as we move forward, particularly in those circles where people will say, we've got to protect the medicine chest clause, so reject any legislation coming forward. I don't think that that's an all or nothing proposition. There is give and take, but I think it's a manageable give and take that can be, navigated through successfully if people are walking forward with open hearts and open minds to that discussion. One of the principles that really stood out to me was on Principle 4. And it's mentioned here, recognizing and striving for cost effectiveness, that traditional medicine and practices reduce costs for healthcare. And that's caused me to reflect on a comment I heard recently. A longtime treaty advocate at a meeting recently stood up and said, our treaty right to health needs to be protected, and it doesn't matter how much money it costs the government to do that. And although I agree with that statement somewhat, I don't think it costs the government money to provide health services to us. There's a couple of reasons why. One is because there's Indian trust monies that the government doesn't talk about that fund most of the services and programs to the underfunded budgets that are currently there. That Indian trust has been there for generations now. It was revealed very recently in a case that was brought forward by Onion Lake Cree Nation when they were fighting back against the Harper government's Accountability Act. There's trillions of dollars that are in that trust. I don't know if it's an implied trust or an express trust, but it's there, and it's money that's set aside for us at treaty time, and it's been continuing to grow as far as I can tell, and as far as I know. I don't know how much of it is fiction, but I do believe in it. I do believe that there's an indebtedness owed to Indigenous people because of the treaty agreements that we made. Now, with that said, as I mentioned in my opening commentary, I believe that we've been commodified as Indigenous people. We did not join Canada's Confederation as full participants. We came in as, I would say, as wards of the state, as has popularly been referred to, identified as the legal Indian in the Indian Act. And we continue to maintain somewhat, that designation as legal or statutory Indians every time we take a new status number off the shelf and apply it to ourselves. The status Indian makes a lot of money for government. And as I said before, if you have a healthy status Indian, they're not drawing on any services offered by Canada. So you're not going to the pharmacy, you're not going to your doctor, you're not getting the surgery done, you're not dealing with a chronic illness if you're healthy. But as soon as you're unhealthy, then all of a sudden that industry engine begins to churn, and you become a contributing factor or a contributor to a very, very expensive and robust medical industry, which spends who knows how much money each year on propping up, pharmaceutical giants from around the world and of course, other aspects of the medical industry. The same has held true in other aspects of our lives as well. The prison system. The prison system for years has built towns around the prisons that have come up in their town. It's been a major employer in many rural communities, not just in Manitoba, but across the prairies. When the local jail shuts down, look at the housing market. It crashes because people leave town and move back to the urban center until the next opportunity arises. That happened in Dauphin, which is in my territory. So when they shut down the jail in Dauphin, all of a sudden housing prices fall because it impacts the economy, because they're putting less of us away in jail. Unfortunately, that's how it is. And that's not the only one. You look at this child and family service industry. It ballooned to a $500 million annual budget in Manitoba alone. And under the previous funding model, which is no longer there, the previous funding model incentivized apprehension because the more children that were in the system or in an agency, the more dollars flowed to that agency. And what was created was an out of control incentivized apprehension industry. So this has happened time and time again. I witnessed it when I became chief the first time under what's called Canada's Economic Action Plan under the Harper government. They flooded millions of dollars into the communities for infrastructure projects, but you weren't allowed to hire local people in some of these projects. You actually just had to flow the money through your band account to your rural supplier to buy materials and supplies for your infrastructure that you're building. It was just the most remarkable thing I'd ever seen. It was a way of flowing cash flow through the communities to stimulate the rural economy. And that's how we're utilized in that dynamic. And it's no different in health, as I said. So I don't believe that cost reduction is actually a motivating factor for governments when it comes to spending on our people. And I would recommend that we all call into question that idea that governments are putting in cutbacks on spending because they need to put in cutbacks on spending for us. I'd say abandon that idea because actually we're stimulating their economy every time we're sick or every time we draw on their dollar. They just use us as a flow through. And that's something my elder told me long ago. And I didn't quite understand what he meant at the time, but now I do because I've got years behind observing this. We can even see it in recent spending during the pandemic with COVID. Federal Liberals just flooded the market with currency. $1 billion here, $1 billion there in spending. And where did that money come from? It's not from the taxpayer. It's from the power of the government to print money. And now we see the consequences of that inflation, right? So cost reduction, I don't really think is a motivating factor in terms of why we're doing this. Although it can be a good political statement, it's definitely not, an entirely practical one in terms of spending. So that's what I had to say about the principles and recommendations discussion. I think Paul hit it right on the head when he mentioned realistic timelines. I think that we have to have informed and very in-depth conversations at many different levels. Beyond the political tables, we need to have our community health directors, even our frontline people who are out there every day providing medical services in our community, visiting the elders in the community, making sure they're okay. They need to have a chance to engage these discussions because they're the ones I believe that are the living proof of the treaty right. They're the ones who are willing to become educated and trained in this space to be able to contribute to their neighbor And that's what I really believe the Treaty Right to Health has always been about, is a willingness and ability to follow through to help out your neighbor when they need a helping hand. I think much of treaty can be boiled down to that very, very basic principle, is how willing are you to help your neighbor out when they're in need. And that's going to take timelines. That's going to take more than, a few months. My only concern is, like I said, I don't want to see this process go the way of Kelowna, with the chance of losing the momentum of the discussion with the federal election. And a change in government potentially. That's the big challenge I see in the coming months and in the next couple of years. So with that said, those are my comments on the day's presentation. Apologize for my throat. It's, this time of year, I think everybody gets a little bit of scratch in their throat, a little bit of a runny nose. I've tested myself 4 times, by the way, and I'm fine. In the last few days, I've done 4 tests and everything's okay. Not everything is COVID, but anyway, those are my thoughts for today. And once again, I just wanted to thank FNHSSM staff for doing the great work. I think we're at the tip of the spear in terms of our ability to engage the issue, to bring the right people to the table, and to get this discussion moving forward. I was at the Treaty 1 to 11 gathering last week. This discussion was introduced for about almost 5 to 10 minutes as almost like an afterthought on somebody's presentation. I wasn't overly impressed how it was characterized or how it was framed. The discussion in Treaty 6 territory is obviously the medicine chest, because I believe the medicine chest is the first time it arrives in the written treaty text in Treaty 6. A very, very critical and a very important part of treaty in that territory, and of course all treaty territories, and rightfully so. It's due a lot of respect, and every effort should be made to protect the treaty right as identified in the medicine chest clause. I do not believe, however, that the issue of federal legislation or legislative process goes to the heart of treaty. I believe it is about covering ground that's been lost in the application of human rights standards, living up to international standards as identified in much of the work that's been identified here today. Whether that be UNDRIP or CANDRIP or US DRIP or whatever you want to call it, many conventions internationally are being missed and not met by Canada right now. I think a lot of that ground can be made up, with the federally legislated process that we're front and center and involved in. So those are my thoughts from today. I was hoping, there'd be some collaboration or some collaborative discussion on this. I know that the PTOs were invited today to be here to be part of this discussion. But other than that, those are my remarks. I thank those who did come out today, who joined us online as well. The presenters for doing a great job, as I knew they would, in the delivery of their portions of the work. I want to thank Willie for sitting next to me here, wondering why is he sniffling and coughing underneath that mask. Willie's a good friend of mine. He's been there, I think, almost most of my time in politics. Willie's been somewhere in the political circle, doing his part and being a community leader as well. So I thank him for being here, and those are my remarks for the day. And I hope everybody comes back tomorrow so we can finish it up. Miigwech.
All right, Chief, let's give our lead facilitator a round of applause. Again, like I mentioned before at the beginning of the morning, we got the right person to lead us in this discussion. That's and it doesn't ever he never gives himself any credit, and I always tell me, well, you know your stuff, all right? And he's well respected. I've seen him speak at many tables, like you were saying, all over the country. So that concludes day 1 of our 2-day meeting seminar on health legislation engagement. So tomorrow, day 2, I'm just going to read over the agenda before we wrap up for this afternoon. We got presentations again from Paul. Well, 9 o'clock, breakfast will be served again. Welcome remarks again by Chief Nipanak, our lead facilitator, and I'll give a summary of day 1 So the first presentation will be about 9:15. That's a presentation on treaty relationship and treaty right to health, like Paul and Derek, Chief Nipanaka had mentioned earlier today. Treaty on Aboriginal Rights, the role of law, the Medicine Chest Clause, Treaty 6, principles for just a treaty relationship, and towards federal health legislation, the process and the parties. Again, that's going to be done by our good buddy Paul Chartrand. Then Paul had mentioned this presentation, and he's looked forward to a presentation on place-based options for First Nations health care delivery and governance. What do models in other countries have to offer? So first time hearing her, she's a doctor, PhD, Caroline Dewey. She's a professor and a senior fellow. She's going to do a presentation on institutional models to consider for First Nations who wish to access taking on the responsibility of providing health care to their members on reserve. The advantages and disadvantages of various models, and the discussion and implications for First Nations healthcare delivery and governance. So that's going to be a very interesting presentation. Then there'll be a summary of principles and recommendations for the morning, closing remarks, and that'll close day 2, and we'll have lunch. That's the agenda for tomorrow. Again, we appreciate the delegates that showed up today, and we had a few online. There's still a few online, but like Chief Nipanaka was mentioning, and we encourage you to come back tomorrow and look forward to the presentations and the discussion as well. So that concludes day 1. I'll see you all tomorrow morning. Have a good evening.